Welcome everyone to EndoscopyNow in today's virtual education program titled Luminal Stenting for the Advanced Practitioner, Challenges and Considerations. I'm Jake Tiemann from Olympus America, the sponsor of today's webinar, and I'll be your moderator. Today we're very pleased to introduce today's speaker, Dr. Kenneth Park. Dr. Park is an assistant professor of medicine and director of third space endoscopy at Cedars-Sinai Medical Center. Previously, Dr. Park also served as co-director for bariatric endoscopy. Dr. Park completed his fellowship at NYU Langone before moving to Cedars for his advanced fellowship. He's a member of the ASGE and the ACG and has numerous publications relating to interventional endoscopy. Welcome, Dr. Park, and thank you so much for joining us today.
All right. Thank you for having me, and thank you for your kind introductions. All right. So without further ado, let's get started. Okay. All right. So this is the title of my talk, Luminal Stenting for Advanced Practitioner, Challenges and Considerations. Disclaimers. These are my disclosures. And so a brief outline for the talk for this evening. So initially we'll talk about the stent, how it began, the origin story, if you want to call it that. And then we'll sort of review the modern self-expanding metal stents, their designs, and why it matters. And then finally, we'll move on to more clinical cases, scenarios, and go over some tips and stent placement cases in each of these different locations in the esophagus, duodenum, and colon. Okay. So stent origins. So the word stent is actually, it's not a Latin word or anything like that. It's actually a name of a person, Charles Thomas Stent, who was an English dentist in the 1800s, developed this plastic substance from a Malaysian percha tree and called it, and used it as a filling substance for tooth after root canal. So this is kind of this cement rubbery thing that he derived from a tree sap. And then around the same time, Dr. Jan Esser, who's a plastic surgeon, used this plastic substance or rubbery substance, and he made a mold and to use as a bridging tool for skin grafts. And he sort of coined the term stent, and he defined it as a surgical mold for bridging tissues until a healing process taking place. And this is sort of his earliest drawing of that he drew of the stent that he used in his sort of surgical cases. But before the words actually stent was being utilized, this Dr. Simons from UK had actually already started using this concept of a hollow substance to use as a stent. And he performed the first successful esophageal stenting in 1885 by using a esophageal semi-rigid tube on a 40-year-old lady with, sounds like she had a diastole esophageal cancer or GE junction cancer. And as you can see in this diagram here, he used this hollow plastic tube, rubbery tube that he inserted through the patient's mouth and then sort of tied a silk suture that you can see up here, and then actually tied it to the patient's ear so that it wouldn't pass on its own. And then first sort of endoscopically placed stents, more so in the biliary realm, Dr. Sahendra in the 80s placed the first plastic stents for biliary malignant strictures. So what about these sort of modern stents, the self-expandable metal stents? So these first metal stents were placed in the 90s in the endoscopic space in the GI, which were borrowed from the cardiovascular stents. They were called wall stents, and they used overlapping two endovascular stents, the esophagus. And then sort of that's kind of the era when people started to start comparing the metal stent versus the back then already available plastic or rubbery substance stent. And multiple studies were done in the early 90s that show superiority of self-expanding metal stents and sort of lower decreased complication rates, including perforation and bleeding. And sort of that sparked a new era of metal stent designs. And these are some of the earlier stent designs. And so it's first commercially produced self-expanding metal stent or wall stents. They were stainless steel most of the times, and not which obviously compared to the current designs, not as flexible and had issues on its own. And they were uncovered, and so the concept of doing a covered stent in places like esophagus were sort of not existent, and they realized soon after that these uncovered stents significant issues with ingrowth. And then there's another sort of different type of stent design, Gentorco Z stent. They were also stainless steel, but they weren't braided. So they had benefit of not foreshortening during development, but also because of its innate stainless steel design, it was still sort of very hard and very high axial force stent, which we'll go over what that means. So moving on to sort of the more modern stent designs. So the material, first of all, has changed over to nitinol, and it's much better metallic material to use in a stent for its shape memory and much improved elasticity, which allows the stent to be more form-fitting. In terms of the actual designs, there are sort of three major ones. The laser cut designs, you can see up top here. The benefit of that is because it's laser cut, it has very high radial force, but also another, I guess, the highlights of this stent is that it has very low foreshortening, stent foreshortening. So technically, you can you can do a stent placement very accurately. The downside, which has it a lot, is it's very rigid. Due to its innate stent design that's laser cut, has high axial force, especially towards the ends of the stents. And on removal, it's easy to fracture. The middle stent here is sort of I guess, the most commonly seen. The woven stents, made famous by, big companies like Boston Scientific or Cook. These stents have very high radial force. The downside of these woven stents is that despite the high radial force, they also have very high axial force, which introduces to a lot of kinking and very high foreshortening, about 50%. And so it's sometimes very difficult to land the stents very accurately because during deployment, the stents foreshorten as you sort of take away the sheath that's covering the stent. And finally, the stent that that I use, I think is the epitome of the correct stent design. These kind of metallic stents is the braided stents, which has very high radial force, but also very importantly, very low axial force, which adds to its high flexibility already. That's innate to its material of nitinol. But because of the stent design too, it helps it to conform to sort of not straight, so sort of bendy anatomical endoluminal space. The downside, again, was very moderate foreshortening, around 20 to 30%. Obviously, better than the woven stents. The reason why these things are important is because if you understand that there are different, not only there are different stents, but with different names and different companies, but there are actually innate differences in the actual the stent design underlying those fancy marketing and names. I think sort of will help you understand why in certain situations not one type of stent or one company stent might be better than another. And I think understanding is very important. So anyways, difference in stent design, sort of the left is your traditional woven stent, and then to the right, as I said, is the braided, the Hanaro stent. Again, you can see sort of the woven design of these nitinol wires versus the actual hook and cross they describe of the braided stent. Some other minor differences in the stent designs as well, and so the Hanaro stent also comes with multiple radiopaque markers to help you determine where the ends are. So sometimes it's kind of hard to see where the stent is, especially where the middle or the ends of the stents are. So they actually have 4 gold markers, both at the ends and then in the middle, to help you sort of land the stent. I visualize them better on fluoroscopy, as well as sort of the 2 lassos on both ends versus just 1. And this is sort of the example of the stent foreshortening that's important to visualize. So this top left here is the braided stent, the traditional wall flex stents, and you can see even here, sort of when you're deploying the stent, how much the stent is sort of foreshortening as the sheath is being uncovered. And then in terms of the opposite way, where you sort of if the stent gets compressed, let's say because of the obviously known stricture, the top is the sort of hook and cross, where if you press it, really you don't really see much of an increase in length. So this is kind of the opposite of foreshortening. Versus when there's a stricture or pressure when you press down on this braided type stents, you see that the stents elongate, which translates to sort of forces towards the ends of the stent that will become pertinent as we go over some of the clinical cases and complications. So as you can see, because of the innate differences, despite of the material, nitinol being the same, because these stents are woven or created differently, there's clear differences in how the stents react once they're deployed inside. And to further sort of describe the differences, we'll talk about a couple of things. To definitions. One, so the axial force I've already sort of mentioned. It's a force that the stent exerts to straighten when bent along the long axis. So it's the torque that the stent applies to, let's say, a duodenum or esophageal wall or colon wall when it's bent. And so any stent with high axial force is less flexible and it has poor conformity to anatomic flexures. So example, the dangers of putting very high axial force stents in duodenal sweep or splenic flexures or hepatic flexures, for example, or even in sigmoid colon, it's very loopy. And it's increased risk of causing excessive pressures and trauma, especially towards the end. Another force, the radial force, it's sort of the outward, both the outward force as well as the resistance to closure that the stent applies in a narrow space. Very high radial force may be good because it lowers migration rate and it'll stick to the stricture rate. But obviously, it'll increase pain and intolerance if it's too high, and especially up in the mid esophagus where the bronchi and the lung structures are nearby. High pressure can lead to increased risk for fistula. So instead of just saying the low axial, high axial force, I sort of created this sort of scenario. So to the left is your woven sort of the wall flex stents, and this is a duodenal stent. Imagine imaginarily situation placed in a C loop of the duodenum. And you can clearly see that on the left, because of its high axial force, the stent tries to straighten. And so even though right after placement, you might be very satisfied that the stent is staying in place, over time, there's going to be increased axial force that the stent's going to exert on, let's say, the duodenal bulb that may create a reason for deep ulceration and, God forbid, perforation in the duodenal bulb, both here and here. But as you can see on the right side, once the stent is placed, the stent does not exert any sort of straightening or straightening force, and it'll just stay there. So what about actual numbers? Is there actual sort of evidence based on, looking at these type of stents? And actually, Japanese group in 2021 compared multiple stents, metal stents, but sort of comparing the direct most common ones. So the crosswire, again, is the braided, the conventional wall flex type stent, and the hook and cross like the Hanaro. And you can clearly see here that this axial force, the torque that they measured, is much greater in the crosswired stent design versus the hook and cross. And so let's say, for example, at a 40-degree angle bend of the of the stent, the stent for the crosswire, the wall flex exerting, let's say, torque of 6 millinewton meter versus, let's say, 40 is maybe 1 point something, less than 2 for sure. And another key difference here is you can see here on the traditional braided stent designs, the dotted line represents the stretching. So the amount of force that the stent will exert after it's bent to straighten versus the bending is to, amount of force required to bend the stent. They're pretty much together. They go hand to hand, meaning it's, very high straightening force as much as bending force. But if you can look at here is that there's a very, very low stretching force for these type of stents, meaning that once the stent is in a C loop, once it's bent in a along a flexure, there's very, very low resistance to strain. So it's almost all the way zero until you get to the 90 degrees. And that's a very, very key difference in stent design. In terms of radial force, they're pretty similar. So for example, let's say a stricture is around 10 millimeter. It's around 20 here. And then for the hook and cross, it might be a little bit better. And both are pretty good for expansion and resistance. But the key difference here was the high and low axial force. And sometimes a lot of papers studying these different stent designs will even refer to them as high axial force stents versus low axial force stents. What about clinically? Are there any clinical sort of proof that these high versus low axial force stents actually matter clinically? And so this study, sort of small sample size, but looked at how the different duodenal stents compare in terms of high versus low axial force. And actually, the high axial force stents had shorter median time to recurrent symptoms, meaning the very stiff stents closed up faster. The patients reported, obstructive symptoms sooner. And as you can see from this Kaplan-Meier curve, the median time to RDO or recurrent duodenal obstruction was much shorter, meaning they felt symptomatic faster. For the W is the wall flex group, and then the N was the NITI. They used the NITI, but so they had the similar hook and cross type design. Okay. What about in the colon? So this is a Japanese prospective multicenter study on colon stenting for palliation and looking at different malignant large bowel obstruction patients. And so they actually only looked at the high axial force stents in around 200 patients. The important thing here was that there was overall complication rate. It was around 47%, and the perforations, which obviously are the most concerning ones for these stent placement, the late onset perforations were all related to stent edge injury, meaning the amount of force that the stent was applying to straighten, and that force was being transmitted at the flexures, at the stent edges along the bowel wall. And then interestingly, they also released, they did sort of a retrospective study looking at other studies as well, and comparing the sort of the D type, again, the cross-link, low axial force stents versus all the, the high axial force stents. The perforation rates were obviously significantly much higher for the high axial force stents. And this was also confirmed on a sort of our sort of multi center study as well. This was a little bit of an older study back in 2014 in GIE, but if you look at down here, when they looked at perforations, colorectal stenting, they try to figure out the risk factors. The stent design was actually one of the things that actually did matter. And if you look at it here, the Hanaro stent had the lowest perforation rate of 4.7% compared to the other sort of the stiffer braided stents mentioned here. Okay, so now we'll just sort of shift gears a little bit to the actual placing stents, some stent basics. Obviously, we talked about stent, opens malignant strictures. Again, is not indicated for intrinsic strictures, given its high perforation rate and migration rate. So it's only indicated for malignant strictures. It covers fistulas. I know we use cover stents for other indications, but only the only indication that's approved for use is use for fistulas. So where can you stent? Obviously in the esophagus, lower esophagus, most common. The upper esophagus, you can stent in the sort of closer to the UES or upper esophageal sphincter, but placement is more difficult. Then you're at risk for patient having those globus sensation because of the stent opening very close to the upper esophageal sphincter. So that might be very uncomfortable for patients. In the duodenum or stomach for malignant gastric outlet obstructions or obstruction in the pylorus or the duodenum, and obviously the colon, left, right. In terms of fluoro, no fluoro, it's definitely helpful to have fluoroscopy. If you're sort of in a situation, for example, in the esophagus, where you'll be deploying a through the scope stent, then potentially fluoroscopy may not be 100% necessary, especially if you can sort of pass through the stricture and confirm placement. However, if you're in a tough situation where there's a complete obstruction, certainly in a more concerning, more difficult locations like in the duodenum or right colon, fluoroscopy could be not only helpful but necessary. In terms of stent size and length, in terms of the stent size, the worst thing you can do is to place a very large stent. A stent that was too big, because for one, patient may not tolerate it. It may increase pain, but also may increase perforations. It may increase risk for fistula development. So you sort of want to aim the stent diameter to match the size of the lumen, and obviously not bigger than that. If you're worried about fistula closure, for example, again, you want to make sure that you want to sort of tailor your stent to the size of the lumen, and not necessarily bigger is always better, because again, it may increase pressure on the fistula and it may actually increase cause tissue necrosis and make the fistula even bigger. In terms of the length, the general rule, you kind of want to have a little bit of a wiggle room. So let's say your stricture is around 5 centimeters. You don't want to, pull out a 6 centimeter stent because it might be a little too tight. So you probably want to sort of go for maybe an 8 centimeter stent just to make sure you have enough of wiggle room above and below the stent. And plus, you also want some room for the flanges to open both above and below the stricture. So something to think about. Okay, moving gears, we're going to start talking about specific sections, specific parts of the body. So first, we'll talk about esophageal stents. So again, these are sort of the indications of a narrow stents that's approved, but we already talked about that. Contraindications, strictures that can't be dilated enough to pass the delivery device. So if the delivery device, the catheter can't pass through because it's so tight or because it's so tortuous, obviously you shouldn't try to force it, because that may turn into perforations or excessive bleeding. If there's obviously a lot of bleeding or visualization is poor, maybe contraindication. Benign strictures we talked about. And also if there's multiple sites obstructions, let's say, there's a patient with, carcinomatosis and there's multiple sites of obstruction, you just opening up one area is not going to necessarily help the patient. So it's, not indicated. So malignant strictures, these are some of the ones that we see very frequently. Squamous, adenocarcinoma. Sometimes we do see more on a rare basis, sort of extrinsic compression from other malignancies, metastases, breast cancer, lung, or extrinsic compression from the malignant lymph nodes. And so this is some of the image of large mediastinal lymph nodes causing sort of almost complete obstruction in the mid-esophagus. And then sort of the chronic fistulas that we can potentially stent to cover up and sort of improve symptoms until more permanent therapy, maybe. So when you're stenting the esophagus, there are three different, you can sort of subdivide the esophagus into three different sort of location based on, the anatomy of the esophagus. top upper esophagus, as I mentioned earlier, placement, you want to sort of aim as far away from the upper esophageal sphincter as possible, at least, a centimeter or two from the US, preferably much lower than that, for the patient's sake, symptoms wise. Avoid larger diameter, definitely more uncomfortable for patients. In the mid esophagus, one thing you have to always worry about is the concurrent tracheal obstruction or injuring the trachea. The space is pretty tight there in the mediastinum. So always worry, back of my head, stenting the mediastinum, if there's a large mediastinal tumor, is not putting a very large stent for these reasons. And so I'll show you an example of such situation. This was a sort of a very large stent that was placed in a patient who had a gastric pull-up for distal esophageal cancer, had an asthmatic stricture, but unfortunately a very large stent was placed. And the patient presented with coughing and pneumonia-like symptoms, and there was a large perforation into the left main stem. And so when we actually reviewed the scan, the left is prior to stent deployment, and to the right, you can see how close, this is the esophagus bottom here. I don't know if you can see my pointer, and the top is the lungs, obviously. And then, so you can see it's only separated by very, very thin tissue. And the only thing that's preventing a fistula formation is this thin tissue right here. And so you got to be very careful of placing very large stents, or being very aggressive for that matter in this tight spaces. And another thing is, if you're the stricture is down here, try not to cross the G junction unless you have to. Obviously, if the stent is crossing the G junction, you're at risk for reflux, and patients are not happy with that. In terms of the distal esophagus, no more than 1 to 2 centimeters of stent should be below the G junction, or the lowest point of the obstruction. The long stent can sort of, cause distal impaction of the stent on the gastric wall. It can cause, gastric bleeding, ulcerations, pain, may even, cause obstruction or decrease in flow. So the goal is to sort of tuck it in as high as possible, within the top of the stomach. Some of the stent types, partially covered, fully covered, all the different companies make it on different diameters and lengths, covered, fully covered. This is sort of just the data aspect of the Hanaro stent. Comes in 18 and 22 diameter size, different lengths, and the delivery catheter 6 millimeter. These are the sort of non-TTS, and they have the TTS versions as well. Potential complications, we sort of talked about this already, so I'll just skip over that. In terms of comparing sort of malignant indications versus esophageal leakage, clinical success, which clinical symptoms of obstruction, obviously much higher clinical success rate, versus slightly lower for esophageal leakage. And then the other thing is the pain. The retrosternal pain is much higher for malignant indications. Usually it's due to having bulky tumors that don't like to be squished by the expanding stent. The esophageal leakage obviously doesn't have a bulky mass, less likely to have pain. So skipping over to a few clinical scenarios. This gentleman I saw, he was 70, was homeless, and had dysphagia symptoms for about a month, and 30-pound weight loss, and had the scan that showed this large mediastinal mass infiltrated in the mediastinum. And when we did endoscopy, this is what we found. It's this sort of completely obstructing lumen, obstructing lesion. And these dark things were a mixture of friable tissue and some of the things that the things that he ate that kind of got dried out and just got stuck on the tissue. So in these kind of situations, absolutely necessary to have fluoroscopy. So here we're using an upper scope. And this is when you start utilizing your biliary cannulation techniques. Basically, you're trying to find a lumen in this tight area using that soft tip and spinning it without forcing anything hard onto it, because obviously the tumor is very friable. and you don't want to create a new fistula into the mediastinum. And for sure, you don't want to put a self-expanding metal stent into a mediastinum. And so here, and fluoroscopy speaks louder. So here we were able to get a wire down, and we actually insufflated with some CO2 to get some gastric bubbles, so we can sort of get a better angle, understanding of where things are. And then we were able to put a stiff wire and then place a small stent, 18 millimeter by 15 centimeter fully covered metal stent. There you go. So the final is this, and obviously this is where the tumor starts, and the tumor ended here, up here, and you can see the markers. And we secured it with a over the scope clip stent fixation device, and you'll see sort of a picture of that on the next case. But the clinical pearl here is that for near complete obstruction cases, again, fluoroscopy is absolutely necessary, and maybe the only way you may be able to put something there. You're utilizing biliary cannulation techniques with wires and contrast, and again, fluoroscopy, just to make sure that the stent is deploying the right space. This case is a TE fistula case. So she was a 59-year-old lady with squamous cell. She had multiple rounds of radiation with some improvement in the tumor regression, but sort of started to have cough and every time she drank something, and there's worry that there may be a fistula development as the tumor was regressing. So again, CAT scan was done. Again, being comfortable with reading CAT scans. Obviously, you're not going to be reading as good as a radiologist, but comfortable enough to gauge what potential complications you might see, and understanding different views. I think is very, very, very necessary and helpful if you're going to be an interventionalist. And so here, looking at both the coronal, axial, and sagittal views, you can kind of see here, this is the area of the stricture here, and maybe potentially a fistula, again, to the left side as the esophagus crosses over. And so we performed an endoscopy, sort of going toward the mid-esophagus here, and we'll notice a stricture coming, so here. So this is, again, likely at the area of the tumor. And you can see a little divot here, which is always suspicious for fistula. The regular upper scope cannot traverse it. We also, going back to the point where whenever you're stenting in the mid-esophagus and there's a concern for fistula already, or a large tumor that you're worried about potentially closing up the airways by placing your esophageal metal stent, you always want to have a multidisciplinary discussion. So in fact, when we're doing this procedure, we had an interventional pulmonary team in the room with us, and they were doing a simultaneous bronchoscopy. And here he's looking for the area of the fistula and trying to identify exact location of the fistula. And skip around a little bit. And so here we go to the ulcerated area suspicious, and we turn the fluoro, and the bronch pulmonary team is doing the bronch, and sort of there's a fluoroscopy shot that because he found an area that looked suspicious, and we on fluoroscopy it confirms. So this is my scope, and this is his scope, and we're sort of right in that same area and confirming that that's the area of the fistula. And so once we did that, we went ahead and placed a long, fully covered metal stent, the smallest that we had, and covered that area up. And this is the picture of the over the scope clip that we used to secure the stent. There's published data that says improved, decreased migration of fully covered metal stents with use of these clips. Okay, moving on to the duodenum. So obviously we used a uncovered metal stents in the duodenum. And the indications is palliative treatment of pyloric or duodenal obstructions caused by malignant neoplasms. Contraindications, again, very similar. If you can't pass the delivery device, shouldn't do it. Too much bleeding, shouldn't do it. Multiple sites, shouldn't do it. Obviously, if you're worried about impending perforations or if the guide wire is not passing, there's no way you're going to be safely able to place a stent, you shouldn't do it. And again, for benign tumors, you shouldn't be placing uncovered metal stents anyways. So these are some of the more common ones. Distal gastric cancers among the pylorus, duodenal cancer, which are a little bit more rare, and then the pancreas tumors. We've seen those a lot, especially the head cancers, the uncinate cancers that sort of grow and cause blockage and impeding of luminal flow, not just biliary, but also luminal flow. Okay, these are sort of technical aspect of the Hinaro duodenal stent. Comes in 6, 9, 12 centimeters in terms of length, and the delivery catheter fits in a therapeutic upper scope, which is through the scope. Obviously, you can do it outside the body as well, but through the scope stenting is what I do. It's more convenient. It's just like the esophagus. There's some things depending on the sites of the duodenal obstruction that you have to be very worried about. So the pylorus, you want to avoid stenting across if possible. Sometimes it's not possible. Stenting across the pylorus increase the risk of biliary reflux, the alkaline reflux, and sometimes it's very uncomfortable for patients. So if the stricture is sort of farther down and there's really no reason for you to stent across the pylorus, you really shouldn't. And then we'll have a case here as well. But if you are placing stent in the duodenal bulb or proximally, there's a chance that the stent will be long enough to be in the C loop here. And so you want to again aim for stents with low axial force, and we'll show you what could happen if you place something in that sort of very bendy area with a high axial force. In the second portion or third portion of the duodenum, obviously one of the most important structures that we deal with as interventionalists, the ampulla, the minor or the major papilla is there. Avoid stenting across it because one, after you place it, tissue overgrowth will cause the ampulla, that area, to sort of get obstructed. And then sort of the only way to really cannulating is blindly, as you'll see here. Thank God the stent metal biliary stent had been placed, but despite that, you'll see how difficult it is. So if you are placing stent in D2, D3, you have to must do ERCP as well in advance, place a metal biliary stent, and then subsequently place a duodenal stent. So here, there was some overgrowth of a uncovered biliary metal stent that was placed, and once you go in, I mean, basically, probing blindly. Imagine if there wasn't already a biliary sphincterotomy or even a metal stent, it's going to be near impossible for you to be cannulating blindly in a native papilla. Okay. Right, and then and D4, same thing with sort of in the pylorus bulb area. Avoid placing very high axial force stents because worry for perforations. So now I know some of you are thinking, well, you don't really place duodenal stents anymore because now we can do this new technique called the US gastroenterostomy. But there are some instances where duodenal stent still is important. Yes, there are multiple studies now. This one by Teo's group that said, obviously the US GE is superior in terms of lower reintervention rate in 6 months, longer stent patency, and symptom scores were better. But in certain select situations, I think duodenal stents still needed. So if the patient, let's say, has very poor prognosis, less than 3 months, or if the patient has very, very large amount of perigastric, ascites, or God forbid, any large perigastric varices, obviously you want to be very careful. And then one thing that I want to mention is, so sometimes, yes, the putting this bypass and GJ bypass or GE bypass, yes, it helps with food, but sometimes it's also you have to have biliary access, right? So let's say it's a patient with pancreatic cancer, and this patient also has liver mets that requires longer stents, like plastic stents on top of the metal biliary stent. And so you might need to bring the patient back for biliary stent exchanges. If the stricture is more proximal to the ampulla, then you get into trouble of, well, your scope can't get there because of the stricture. So you might have to sort of place duodenal stent for access for biliary stent exchanges. And then one thing that I do want to mention, and not a lot of providers recognize, is this concept of sump syndrome. So I'll show you what I mean. So let's say this is a cancer, head cancer, and so yes, the patient has biliary obstruction. You place a metal stent. You think that's done, but then the patient comes back with recurrent ascending cholangitis. You keep sweeping out junk from the duct, and you're wondering, why is this patient keep coming back with cholangitis? Well, it's because you have a closed outlet here, and despite this patient having potentially another route for food to get through, some of that through gastroenterostomy that you created, some of the food will go into the pylorus and start accumulating here, and all that food will reflux up into the biliary tree, basically create like a cesspool. And this is similar in concept to what we used to see a lot when biliary surgeons used to do a lot of colodocal duodenostomy for large stones, and they would used to create this anastomosis so that the bile can drain down via different opening, but then they would create this stagnant pool of bile, static bile, stones, maybe some food residue, and create sort of a nidus for infection. And this is a classic biliary sump syndrome, and this is sort of a newer version of our modern version of a sump syndrome. Now that we're doing a lot more gastroenterostomy bypasses the US and leaving duodenal obstruction alone. So it's something to think about. And so how to treat that? Yes, you have a gastroenterostomy somewhere else, but it might be helpful clinically to open up the duodenal obstruction as well to allow some of this food and stuff, debris to drain down distally. Okay, I talked about this already. So I'll show you, this is not a case on how to treat a duodenal obstruction. This is this one. So, but rather what could happen when you place a high axial force stent into the duodenum without really thinking ahead. So this patient had duodenal head cancer, complained of obstructive symptoms. Previous provider had placed a uncovered duodenal stent. Thank God he or she had done an ERCP correctly prior to placing this duodenal stent, but they had placed a braided metal stent in a very angulated C-loop of the stomach, in the duodenum rather. And so here you can see that the scope is in the stent. On coming back though, you notice that there's a large defect. And I don't know if you saw it on the way in, but there was a deep ulcerated area. And so switch scope and going back in, and now you can clearly see that this perforation is very deep. You're looking at the liver to the left here, and it's right at the stent edge where that serrated stent edge almost acts like a saw, and then sort of grinding down the mucosa, the submucosa, and obviously the musculus propria until a deep ulcer developed and then eventually perforated through. And so, and if you look at the CAT scan, the way the stent is oriented, this is the sagittal view, this is the coronal view. You can see how the stent is almost straight despite being placed in a C-loop. And it's digging right into the liver, which you saw on the endoscope. And so this is the danger of placing a high axial force stent in a angled area, because the stent, is trying to do its thing to straighten out, but guess what happens? It can perforate. Okay, and then sort of compared to that, this is an example of a low axial force duodenal stent being placed in a patient with cholangiocarcinoma who unfortunately have lymph nodes and also develop duodenal strictures. And this is a good example of patients also requiring stent exchanges and biliary obstruction, biliary access. So this patient actually already has a gastroenterostomy US guided, and so but this duodenal stent was placed to allow for easier biliary exchanges, stent exchanges. So here you just saw the glimpse of the gastroenterostomy stent, but the duodenal stent was being placed specifically for stenting to allow stent exchanges. And the important thing here is also to note is to allow to sort of gauge where the distal end of the stent is in relation to the ampulla. We went over that during the things to look out for in second and third portion of the duodenum is to make sure if you don't need to cover the ampulla, don't cover the ampulla. And so the distal end of the stent should be just above the level of the ampulla so that the stent exchanges can be done. So this is the view. So the ampulla is here, not covered by the stent, and you have easy access to the stents so you can do the exchanges. And this CAT scan shows, in comparison to the previous case, where the stent tried to straighten and cause ulcerations, you can see how despite, this is after maybe 3-4 months after the stent placement, you can see the C-loop of the duodenum is intact. The stent is not trying to straighten, it's staying in that sort of bent, almost 90-degree shape. And there's no ulceration or any danger of ulceration, clearly. Similar thing in the colon. We use uncovered metal stents. Indications very similar to duodenum, palliative colorectal strictures by malignant neoplasm, intrinsic or extrinsic. As we all know, these uncovered metal stents, whether it's duodenum or colon, they have a lifetime on its own. As 3 to 4 months go by, because there's no coating, there will be tissue ingrowth and potentially reobstruct without a patient undergoing surgery, right? So either palliation or bridge to surgery is the most appropriate use of these stents. So in the colon, we talked about different malignant strictures. Similar complications to all other stents, perforation, bleeding. And we talked about the stent occlusion from tumor or potentially stool. Migrations, not too much of an issue usually for intrinsic, especially for intrinsic malignancy of the colon. Sometimes for extrinsic compression from outside in, the stent may still migrate despite being uncovered, but much lower. Some of the different lengths and sizes that's available. So we'll just go over some cases here with the colon. This gentleman, 86-year-old, presented with some bleeding and abdominal pain. Interestingly, at home, he had already sort of stopped eating. So he was on liquid diet for a very long time before coming in, but finally went ahead and got a scan and a colonoscopy done that showed a large mass in the sigmoid colon. You can see it here, right there. And then this is what it looks like from the inside. Too tight to pass through with adult colonoscope, and similar to what we used in the esophagus, we're using wires and different techniques to get through. And then here we placed a very stiff wire. This is what it looks like right after the tumor, as we traverse the tumor. Left the wire, and then we're exchanging. And here, so you're placing stents from distal to proximal. And this is the final product. Because of the gold beads that you can clearly see where the middle of the stent sits, and it's sitting right at the center of the stricture. Maybe a little bit off, but pretty good otherwise. And everything went pretty well. And so when we do a final shot, the stent is in a good place in the sigmoid colon. Let's see, D3. So maybe a couple more cases here. So 68-year-old with observation for 1 week. This patient actually had ended up having a GYN uterine type cancer. But so this is an example of extrinsic compression, malignant extrinsic compression causing severe colonic obstruction. And this is the CAT scan to the right, where this is the scope. There was already a decompression tube in across the stricture, so it was much easier to sort of navigate. Let's see if I can fast forward a little bit. And so you can see sort of this nodular mucosa appearing, and then the stricture, the epicenter of the stricture is just around here. Then, yeah, and then sort of you flip in to the colon that's significantly dilated, filled with stool, despite having this decompression tube. So, yeah, yes, there is no intrinsic tumor, but once you confirm that patient, had already GYN type cancer and it's extrinsic compression, you are able to place a colonic stent. And for this patient, it was more for palliation. Again, place the wire. And you can be, for this case, because you were able to cross the stricture with your scope, and if you're doing a through the scope stent deployment, you don't necessarily have to have fluoroscopy, but having fluoroscopy will help you in terms of better sort of knowing where your scope is, where the stent is, where the stricture is. So it's generally recommended. Right. So good thing to show here. Again, if you look at this picture, some providers will say, wait, this is sigmoid colon, it's much too angulated. There's no way there's no way that I'm placing a metal stent that's very angulated, almost 90-degree turn in a sigmoid colon. Normally true, but knowing that I'm placing a very low axial force stent, I felt pretty comfortable placing the stent. Again, from that first few slides, looking at comparing the axial force, the even lower than the initial placement is the force that the stent exerts to straighten out is almost near zero for these type of stents. So I felt comfortable placing it. And then this is a picture of the same patient 1 day later. And you can see that the stent is almost fully opened and comfortably sitting here in this almost 90-degree angle. And the patient, there's no complication thus far of any perforations or ulcerations or anything like that. Versus a similar sort of case. This is for a case that we published in a while back, just looking at this was a braided stent, evolution stent, which is braided, and because the stent, the stricture was very, very tight, and you can see, as I showed you, the stent elongates and gets very, very narrow in the middle. And despite having the stent placed right in the middle of the stricture, it wouldn't fully open up. And unfortunately, this patient ended up eating cherry, despite telling her not to eat anything high residue. And not only she ate cherry, she didn't spit out the pits, and all the pits got stuck in the middle. This one particular pit got stuck in the middle of the stent, and she represented with obstruction. This is another good picture of how well these Sonaro stents do in sort of a very angulated space. This is actually a case that we just did maybe a week or two ago of another unfortunate lady with malignant colonic obstructions. Again, it was in a sort of very angulated sigmoid colon type, where again, if you are placing a high axial force stent, you might be worried of creating an ulceration or perforations, especially at the ends. But I felt pretty comfortable, and this is the picture 1 day post stent placement, again in a very nice, almost 90-degree angle, fully pain, and the patient went home, able to have bowel. So that's pretty much it. Again, I went over the reason why I went over the stent designs and differences and the companies that make the stents is, again, not only for marketing reasons, not only the royalty reasons, or you're loyal to one brand or another, but there's actual design differences. Despite all the stents being made out of nitinol, there's definitely innate stent design differences that, again, as you've seen, hopefully you've seen today, that makes a clear difference, especially in the colon and duodenum, especially in the tight spaces around the bends. So hope that was helpful.
Thank you, Dr. Park. That was really fantastic. Thanks for sharing your pearls and tips on stenting the GI tract. So we're going to move on to the Q&A session with the time we have left. If you haven't already, please put your questions in the Q&A at the bottom of your screen. And while we're waiting for one or two more to come in, I just want to remind everyone of a upcoming Endoscopy Now webinar on Friday, September 13th, 1 p.m. Eastern Time, called Techniques, Knives, and Imaging Modalities, Maximizing What's Possible with Your ESD Equipment. So we'll hear from Dr. Kaminski from Poland, as well as Dr. Schlachterman from Thomas Jefferson University, about their knife selection, Olympus knives, and also how they use their technology to treat bleeds. So Dr. Park, thanks again. So the first question here is related to the nitinol construction of the stents. Are you able, because they're made of nitinol and titanium, are you able to place metal stents on patients with nickel allergies?
Yeah, I mean, so I think that's another sort of good example of utilizing the stent innate material. But I mean, a lot of times, especially if the stent is covered like with silicone and other sort of material, it's not skin contact as well. And so I think a lot of times the patients will tolerate it. And so I haven't had really issues with that.
Yeah, thank you. The next question is going back to your TE fistula case that you presented, and this attendee is asking, is it necessary to put two scopes to confirm the position of the perforations?
So that one was, the important part of that, the whole case was that, one, recognizing that in those tight mediastinal spaces where things can overlap, again, the space is pretty tight in the mediastinum. And so let's say there was a bulky mediastinal tumor. If you push from the esophagus side, that tumor's got to go somewhere. So it's going to get pushed potentially, especially if there's already sort of narrowing in the air spaces, may potentially occlude the airways after you place your esophageal stent. So in those situations, again, you have to have a multidisciplinary conversations, especially with thoracic surgeons or interventional pulmonary team, about potentially simultaneously placing a bronchial stent before or after you place your esophageal stent. Now, for this specific case, the reason why I had them actually come back to do the simultaneous exam was because when they reviewed the CAT scan, they said there is no fistula. And when I went to do the endoscopy with the small scope, I saw a hole. And when I was watching the anesthesia and tidal CO2, it would just shoot right up when I was pumping CO2 in that little space, and actually called them back and said, listen, there is a fistula. And so they actually wanted to confirm. So that's why we did that sort of meet and greet with the airway and the GI scope. But yeah. So, but I mean, the point here was that you need to have a very close relationship with your pulmonary team, especially when dealing with long bronchial issues.
Great, thank you. Okay, this next question is related to retrosternal pain when placing esophageal stents. Can you speak to your experience with that, and in particular with placing Honora stent?
Yeah. So unfortunately, it's one of the things that limits stent usage, especially for very hard or bulky or large tumors, especially if they're a little bit higher up. Generally, the tumors a little bit lower tend to be more well tolerated, but certainly having a stent that is softer, and then obviously, if a patient you place a stent in comes back with pain, you should always try to downsize the stent to see if they can tolerate better. But sometimes the patient can't tolerate stent, period. And we've had certainly had those situations where it was very big dilated esophagus. Certainly we thought they could tolerate sort of a normal size stent. They couldn't. We even downsized it even further, still complained of severe chest pain. So we ended up referring them for a cryo or other sort of therapy that will sort of palliatively decrease the bulkiness of the tumor too, so that they're able to take in oral intake, whether for pleasure or for nutrition.
Thank you. Okay, this is a question from a physician that says that they have placed stents for external malignant compression throughout the GI tract, and it works most of the time. Do you have any data to show the effectiveness in such situations? What's your
Sorry,
experience with this?
can you repeat the question again?
Yes, so they're asking about your experience with malignant external compression and stenting, success and data to back it up.
Yeah, so I mean, in terms of as I spoke to it earlier, the extrinsic compressions, for example, in the colon, there's higher risk of stent migration despite of having the uncovered stents, because again, the amount of the narrowing is not going to be usually not circumferential. It's only one-sided, so it's usually one side of the colon or the right side of the colon that's causing narrowing, and so. Versus a large colon mass, usually is going to be circumferential. So your stent's sort of situated right in the axial, the center of the malignancy, and so less wiggle room for the stent to move and migrate. And so the migration rate's a little bit higher, and certainly agrees with my the personal experience that I've had. Yeah.
Okay, thank you. I'm going to combine these next two questions for time here. So, what is your opinion on colonic stenting as a bridge to surgery? You know, it's not maybe not as done as much as it could be. What are some of the reasons for that? And then also, what is the common length and diameter of colonic stents for left-sided obstruction tumors as a bridge?
Yeah, so there, ever since development of these stents, there's always that questions, surgery, emergency surgery for colonic obstruction versus, uncovered metal stents as bridge. For majority of the studies that I've looked at, there is increased evidence of utilizing metal stents as a bridge to decrease, the stoma rate, decrease the rate at which the patients post-op will be able to tolerate soft diet, and all these different indices suggest that yes, unless the patient is pending perforation or there's already concern for colonic injury, that you should try for metal stent, especially in the colon, especially in the left colon, to see if you can sort of help the surgeons prepare the patient, prep the colon, and sort of go for a more controlled situation. In terms of the lengths of the stricture, lengths of the stent, diameter of the colon, again, it really depends on the patient population, the patient that you're stenting. In terms of the lengths of the colon stent, you don't want to obviously place a stent that's too short or too long, and so during the procedure or prior to procedure, you should learn to review again the different cuts of the CT scan, axial, coronal, or sagittal, to figure out and estimate what the stricture length is from the most optimal view of your CAT scan. And then again, first of all, before you start, make sure you have that length stent in your unit. But also during the procedure, you can utilize different things. So for example, if the stricture allows for passage of smaller scopes, then you can use the scope as a ruler. So you'll go past the stricture and then leave a wire, and then as you pull back, you can measure what the length of the stricture will be. The reason why you don't measure on your way in is because obviously you can put in loops and you can easily overestimate the length of the stricture. So that's why you should learn to measure on the way out so that your scope is as straight as possible. And then but again, if you can't do that, then you can utilize your biliary stricture sort of skills, and you can use a catheter, whatever catheter that you have, load it over the wire, and use that as a ruler to say, hey, this is, inject contrast, and this is the distal margin or proximal margin of the stricture, and you can mark that on your catheter and then pull back until you see the catheter on the distal end of the stricture and sort of better estimate exactly what the exact stricture length is. And again, you want to add a couple centimeters to that because again, you want to have some wiggle room for the stent to open up, as well as as even these nice narrow stents, they do foreshorten, around 30%. So you have to put that into considerations.
Yeah, thank you, Dr. Park. So I'm sorry, there were a few more questions, but we're over time here. So I just wanted to say this concludes our discussion. Thank you so much for joining today on the EndoscopyNow webinar, and thank you to Dr. Park. Thank you for joining us today, and have a great evening. Thank you.
Thank you.